Now that you understand how to diagnose a problem, you know how to read your MRI and X-rays and know which tests to order, except for EMGs, which we'll cover a little later. We're going to talk about what do you do with these people once you got them. So general principles and treatment of spinal disorders. So how many tools do you have in your toolbox to take care of these people? So obviously you can stretch a tendon or a muscle or a ligament, you can strengthen, you can condition to allow long-term conditioning, pelvic station or angulation, ergonomics, weight loss. I mean, you can go through the whole list. You have a ton of tools in your armamentarium. The question is, how do you use them? Some are general and some are more specific. So my least favorite thing to see in the gym, more people come in with this problem than anything else other than the flies, the dumbbells, or what do you call them, the kettlebells. So stay away from this, but I put that in there so we can understand. So general rehab, you want to strengthen and condition the muscles, obviously. You want to stretch ligaments, facets, and discs that need to be stretched and not stretch the things that don't need to be stretched. You need to reset pelvic rotation, which is important. And you need to teach patients to do ergonomics, mechanical activities to prevent aggravating the disorder. This is, the key really is prevention more than treatment per se, but let's talk about all of this. So, you have to understand natural disorders. Some disorders were stabilized become less symptomatic with time. For example, annular tears. Somebody comes in, they can't stand, they can't walk, they're miserable. Sometimes we admit them to the hospital. Are these people going to be that way forever? No. Natural history says that they're going to become less symptomatic with time. The annular tears will scar in the outer third of the disc over 3 months. Disc settling will many times allow eventual stiffening due to fibrosis, and what we want is stiffness. In the lumbar spine, if you've got a disorder, stiffness is generally better than motion, believe it or not. Injured facet capsules will develop fibrosis, limiting facet motion and stress. So some things will get better over time. My favorite quote from Thomas Edison is that the purpose of the doctor is to entertain the patient while nature affects the cure. And it's true. You've got to keep them comfortable and take their mind off it until nature does get them better. So, but you have to know your urgent indications for surgery. Obviously, Cardiovascular Syndrome, we talked about it. You guys know how to look for it. You know what questions to ask. H&P with progressive motor weakness. Somebody comes into your office with a foot drop and they're not getting better. That is an indication for surgery. Obviously, myelopathy from cord compression and severe instability. These are no questions asked. They got to be fixed. So see this guy? Massive herniation, numbness around the bowel and bladder, his perianal sensation doesn't work, his rectal exam is abnormal, he needs to be fixed now. So, what do you have to worry about? Well, if you push too hard, it's the delayed inflammatory cascade. So you stretch a nerve root and they say, God, that feels good, and you keep stretching it and stretching it. That night they're miserable and they hate your guts. What you've done, you've actually gone beyond the normal stretch, and now you have an inflammatory situation. The inflammatory cascade takes 6 to 12 hours, so they won't know that they're pissed off at you for 6 to 12 hours. And so it's not predictable, and this is the art as well as the science of getting people better. How much do you stretch them? How much can you push? And this is a feel that you have to develop as a therapist or as a physician or as a manipulator. Hamstring stretching for everyone. You have to stretch these hamstrings because they will condition and tether the lumbar spine. So when you bend forward, you think the lumbar spine moves, but it only moves about half. The pelvis moves the other half. If you have tight hamstrings that lock the pelvis, where does all the motion go? Lumbar spine, right? So stretch the hamstrings and stretch them again. But you've got an issue, because what does this also do? It what? Yes, it tensions the sciatic nerve. So people with herniated discs will hate you. So again, this is where you have to recognize what the problem is and how to deal with it. Again, the normal lumbopelvic rhythm, you first bend from the lumbar spine, remember 60 degrees down to 20 degrees. So you've got a delta, it says 60, it should be 80 here. And then you get an extra 25 degrees, that should be about 40. But nonetheless, you can get an idea that the lumbar spine takes most of the motion, but this is where the hamstrings come in. If the hamstrings are locked, you don't get any of this, all of that. So you can actually teach them to reverse their normal lumbopelvic rhythm. We saw that when we looked at physical examination, where people who are really strong lock their back and they bend forward only through their hips. You can teach them to do this. So if you teach them to lock their lumbar spine when they go down and only round at the bottom, or even if they're absolutely miserable, not even round, but stay like that, you can reduce the amount of stress in the lumbar spine, teaching them how to reverse the normal lumbopelvic rhythm. Braces. Braces work in general by pushing the diaphragm against the abdomen, increasing intra-abdominal pressure. It's opposite the normal action of the abdominal muscles. You actually push your belly into the brace instead of pulling it in. So it is when the brace is worn but only temporarily tightened, so these new straps keep the brace in place and you don't tighten it until you're going to load, you can protect the lumbar spine. Rigid braces increase the stress on L4 to S1. So if you have one of those plastic braces that comes down to here and you've just done an L5 S1 surgery, do you want to put them in a heavy plastic brace? No, you make them worse. The only way you're going to immobilize the pelvis is with a hip spica brace, and I promise you people will hate you for that. It's a brace that has a cuff that attaches to the thigh that you lock when you stand up and you release when you sit down, and people hate them. Sometimes you have to use them. Cardiovascular training. If there's one thing you can take back from here, plays a huge part in recovery. All individuals can improve their cardiovascular system. It's been demonstrated to significantly help with pain reduction as well as endurance, and a cornerstone for rehabilitation. More emphasis is required. So if somebody is even with isolated disc resorption, can you get them, and they're miserable, they can't load their spine, you can do other things. You can use a bicycle ergometer for the hands. You can teach them how to do things that don't stress their spine. Anytime somebody comes in with a miserable spine, you start with a neutral spine conditioning program. You find the neutral pain-free position and have the patient lock the lumbar spine in that position. And this locking avoids the extremes of painful motion. People with acute, what I call low back attacks from an annular tear, they can't even get up. They need 3 or 4 days maybe in bed, but you have to start them moving. The entire program can be initially performed with simple exercise equipment, exercise balls, floor mats, hand weights, and elastic bands. So you just have to get them moving, but within the pain-free zone. So let's talk about the core, because I'm going to focus on the core a lot here. So we talked about the abdominal muscles yesterday that insert into fascial bands and only partially into bone down here in the iliac area, up here in the, excuse me, I can sneeze. It must be the heat coming on. And then into the ribs. And so this creates a tension band is really what it does. They can't individually, oh, did I lose it? There, it can't individually affect stability. So we talked about these muscles and how they work, and they don't work like a typical joint does. Biceps, triceps, reciprocal inhibition. You have to contract all of these muscles together, both in front and back. There is no reciprocal inhibition. So you can't protect the spine. The whole core tightens up. So what happens if you don't have good strength is you get what is called Dunnlop syndrome. You guys know what that is, right? Where the belly Dunlops over the belt. Okay, that was a joke. You can laugh. So you have Dunnlop syndrome. So with that, if you don't increase the abdominal wall pressure, the diaphragm drops, you have increased lumbar lordosis, and you don't have any load sharing whatsoever. If you tighten up the lumbar spine muscles, it's like a snake tightening over a water balloon. It distracts the abdominal contents. And so this is what happens. When you contract your core, you increase the abdominal cavity pressure, it increases the pressure against the diaphragms, and it distracts the spine and load shares. So core strengthening is huge. It is the key to prevention. You have to have a solid core. So I'm a huge fan of Pilates. It's an important way to strengthen the muscles. You can do it other ways, but it's the easiest way I think that people can do it. The other thing is to prevent an injury, you have to understand the mechanics of the spine. Y'all remember in high school, you have the fulcrum here and the weight with an opposite force holding that thing up. So that is a balanced system. But if you move the fulcrum to here, then unfortunately it takes significantly more energy to balance that weight. So lifting, if you lift towards your feet, the fulcrum is in your spine. If you keep the load close, the stress is much less. If the load is out, as so many people do, that's when you're at risk to injure your back. And if you remember what I call the running start, if you already have a degenerative disc, and here's a normal disc, you'll see it doesn't displace much and takes a long time to displace to its maximum. A real degenerative disc displaces immediately and goes up to a much higher displacement. So it's a running start to get a tear. So you've got to engage the core before you start to load. Another mistake is done, you engage it as you're loading, bad idea, engage it before you start loading. And this is a great diagram. So a 200-pound or 90-kilogram weight with flexion and partial body weight recovery, and here's your fulcrum. How many newtons of force do the muscles have to generate in order to protect that? 8,200 newtons. What can a multifidi muscle generate? 60. Do you have enough strength to resist this? No, you're depending upon your ligaments, tendons, and discs, and this is the perfect recipe to hurt your back. And again, we talked about the multifidi and the erector spinae. The erector spinae inserts into the pelvis and really doesn't insert into the lumbar spine. It starts to insert toward the thoracic spine. The only muscles that individually insert are the multifidi and rotator, and they don't have the strength. So as much as I'd love you to strengthen the multifidi all day long, it's sort of a fool's errand. You want to do it because that'll help, but you want to make sure you don't get into the position that those multifidi muscles don't work. And you remember BLT, right? You have the integrated lamina. There's 30 of them in the disc, and they all go in different directions. So rotation one way will tighten all of them and loosen the others. And again, we're harping on, what's that famous? Bacon, lettuce, and tomato, BLT. So if you bend and load the spine when you twist, that's almost 90% of the time we'll hear about disc herniations and annular tears when they do that. And there are times you can't even predict. You put a suitcase in a car trunk, you drive around, it shifts, and you go open the trunk and it's over to the side, and so what are you doing? You're BLTing. So you have to start being cognizant of preventing that. So people lift with flexion and rotation as well as load, and it's a learned behavior. Very common. It's easy to plant your feet and to move your torso. But you can't. You have to move your feet and keep your torso planted. And that's where physical therapy comes in. You've got to teach them new algorithms to move so they don't put their back in jeopardy. That's the key. So in a neutral spine program, the spine is balanced. You avoid shear loads and flexion extension. The spine is locked. The core muscles are engaged. Motion and range of motion is through the pelvis. And you're stiffening the spine. The spine, unfortunately, is not your friend. And so if you stiffen it and prevent the loads from occurring on the spine, you'll prevent the injury. So pelvic station. You can affect the spine by how you rotate the pelvis. Weight-bearing percentages in different spine positions. When you have a normal lumbar lordosis, we've already talked about it, the spine loads through the disc by 70% and by the facet by 30%. When you flex, you load the discs 95%. Extension loads the facets almost 70%. So you can onload and offload structures if you teach the pelvic tilt. Bending the pelvis forward or a forward rotation increases the lordosis, and as we said, what happens to the discs here? Offloads, right? You're loading the facets. If you flatten the lumbar spine, you load the discs and offload the facets. But what is this going to do to stenosis? It's going to make it better, right? But if you have a crappy disc, an L5-S1 isolated disc resorption, this position is going to be painful. So sometimes you can't win. You have to deal the best you can. So anterior pelvic rotation will unload the disc, load the facets and pars, reduce the tension on the sciatic nerve, but increase the tension on the femoral nerve. So now you have to know disorders. Do you have a femoral neuropathy? You don't want to do that. But if you have a sciatic neuropathy, you do want to do that. So now you have to differentiate what you have. This is what the first part of this course was. So when you bend backward, you decrease the diameter of the spinal canal and foramen, right? So what happens to stenosis patients? They get worse. They don't like that. They want to have their spine flat. It increases the lumbar lordosis, but it does stabilize a thoracic hyperkyphosis. So if you've got somebody with a big thoracic curve, you want to teach them how to do this. What are the problems, of course? You aggravate stenosis, you aggravate pars fractures, you increase the shear forces on an isthmic spondy, you aggravate facet disorders, and you aggravate femoral nerve disorders. So if you know your diagnosis, you can know how to put these together. Posterior pelvic rotation loads the discs, but it unloads the facets and the pars. It increases the tension on the sciatic nerve, but conversely decreases the tension on the femoral nerve. It increases the diameter of the spinal canal, lateral recess, and foramen. And so basically what you're doing here is you're opening the canal and loading the discs. Yes, ma'am?
I'm confused. When you anterior pelvic tilt, aren't you lengthening the posterior, like the glutes and that?
When you anterior pelvic, yes, you are. Well, you're not lengthening the glutes. They're contracting.
Wouldn't that tension the sciatic though?
When you do something like this, this will tension the sciatic nerve when you posteriorly rotate.
It's not slackening?
No, remember the nerves come out behind the pelvis. So if you flex, you're going to have more problems. The flexion comes through here. This shouldn't cause any further problem. However, you're right, in a typical herniated disc, patients will extend. So risks of flattening the lumbar spine aggravates degenerative disc disease, aggravates Schurman's and osteoporotic hyperkyphosis. So how do you set the sacral angle? Well, you just study the muscles. The anterior muscles, the rectus and obliques, will posteriorly rotate the pelvis. And the same things when you have buttocks. If you have glute max and hamstrings, it'll posteriorly rotate the pelvis. So people with isthmic spondylolistheses will like this position because there's less shear. That's why they end up getting high or contracted hamstring muscles. So it's a simple matter. What I have my patients do, we call it the Flat Earth Society or Flat Black Club. Just have them back into a wall and then put your hand in between their lumbar lordosis and tell them to smush your hand. They have to flatten their lumbar spine, tell them to hold it and walk away from the wall. I mean, it's very uncomfortable initially, but they can eventually adapt and learn that position. Did I lose a slide here? For the opposite, this is simply a matter of, as I tell my patients, stick your butt out, because you want to increase the lumbar lordosis. And you can teach them the specific angles. For example, extensor spinae, You want to strengthen the abdominal wall. You don't want to have as strong as you do the psoas muscles and the hip flexors. Oh, the other thing is, if you want to hold this position and they're sitting in a chair, just simply put a towel roll behind their spine and let them sit back against it, and that'll reduce some of the stress. So, we have to talk about traditional therapies because there's a lot of information that may not be perfect. So Mackenzie, the old story, Mackenzie was a New Zealand guy, left a patient on a table in a hyperextended position, forgot about him, came back 20, 30 minutes later, and he says, boy, thanks, doc, I'm so much better. And he says, the key is extension. So he suggested that all spinal pain can be attributed to alteration of the position of the disc's nucleus pulposus. So it's all an extension program, and it works great for degenerative disc disease. What doesn't it work great for? Stenosis, facet problems, isthmic spondyes. So what you want to do is know what your parameters are. Williams flexion exercises. He said to stand erect, humans severely deform the vertebral column, redistributing body weight into the posterior aspect of the lumbar spine. So he wants you to do flexion. And flexion is great for stenosis, for patients with other problems. But Williams flexion is no good for what? Discs. So you have to pick your poison and know which one you want to do. And this just increases the response time. Manipulation we didn't talk about, but Maitland's manipulation or chiropractic manipulation will aggravate instability, degenerative scoli, and degenerative and isthmic spondyes. So if you're a good manipulator and you can isolate the area you manipulate, so if you're going to stay away from L5-S1 and you can manipulate only the upper ones, God bless you, do it. But most of the time, when you do side posture and specific manipulations, you're going to mobilize everything. So one thing that I like to talk about is functional assessment. This is standard physical therapy. A good basic analysis of pain generation using biomechanics, but the why is missing. This is the course to give you the why so you know what you can use and what you can't. One thing I see is over-rehabilitation. You get a 75-year-old who's a shot putter and she has never bridged before. Probably don't have her bridge to try and get her better than she was prior to her injury because you'll aggravate her. Just, learn the pre-injury parameters. So don't push patients beyond previous limits. You can take some patients and make them super athletes, but you're never going to make me a super athlete. So you got to remember that. Again, we talked about manipulation. It's great for restricted and contracted structures, can restore the normal range of motion and reduce the stress on facets, but it mobilizes slips and scoliosis. And a higher mobilized degenerative scoliosis is going to do what? What's gravity doing to it already, right? It's already pushing it down. You mobilize it, it's going to make it a little worse. So you can get temporary relief, but you don't want to work on it and work on it and work on it and make it more mobile because you're going to make it worse. I love modalities for inflamed tissue. Ultrasound, electrical stim, TENS, high current TENS, diathermy traction, iontophoresis. They all work well in the proper setting. This one shows it right over a condyle, maybe not as good as it should be. But nonetheless, these things work well. Iontophoresis, I'm not sure if we still continue to allow therapists to use it. I hope we do.
Medicare doesn't pay for it.
It doesn't?
Nor does it pay for ultrasound.
Is that right?
What about commercial payers for ultrasound?
Commercially, you can get away with it. Work comp, you can get away with it.
So I had a bad bursitis, lateral trochanteric bursitis, and they put one of these beautiful pads on me here, and it has a little battery in it, and the molecules are driven into your skin because they're charged. So for example, steroid was negatively charged, they put it over the negative pad, and my pain went away, and it was great. These things work wonderfully when they work. Medications. You gotta know about medications because they can be used to reduce pain, inflammation, relax muscles, and reduce nerve irritability. They can be used for treatment of depression and sleep disorders. They're wonderful used correctly. They're terrible not. Remember this picture, right? You have the arachidonic cascade, you have leukotrienes and prostaglandins. Aspirin and nonsteroidals block this pathway only. Steroids block the tissue injury into arachidonic acid. So patients who come in with low back attacks, it's an annular tear, or red hot radiculopathies without motor weakness, what can you do? Put them on an oral steroid. If you're not a prescribing individual, get to know your family doc well and say, what I like is 4 milligrams of Decadron twice a day for 5 days. If you go back and you want to talk about history, the Medrol dose packs thought that you would develop an acute Addisonian crisis if you gave them steroid. So it starts with a high dose and it weans down to a low dose. But it's not as effective as Decadron, and we in 25 years have never seen we've seen one person with a Cushing syndrome. That's where the swelling occurs. That goes away when you stop. But other than that, we've probably given it thousands of times, and 4 milligrams twice a day for 5 days seems to be the appropriate dose. So if you give people nonsteroidals, let's go back to nonsteroidals. You have to take it before the onset of arachidonic acid production, meaning that you have to take it pre-activity. Don't try and use these things as pain medications. They don't work as well. They block the transition down this pathway, but if you already have things leaking down this pathway before you take it, it's not going to be as effective. And remember how long they last. Motrin only lasts for 6 hours. If you're going to have somebody on an all-day hike and they take Motrin in the morning, what's going to happen in the afternoon? They're going to be miserable. But if you give them naproxen is 12 hours. And if you give them Mobic, it's 24 hours. So learn your medications and their timing. Now, what are the problems? Obviously, gastritis. I can't take these things because my stomach is on fire. But my wife can eat them all day long. It reduces new bone formation, so you don't want to use it in fusions because it is an anti-inflammatory. Does have some toxicity in some cases, possible stroke and MI risks, but not with aspirin, allergic reactions, and if you're going to give it on a chronic basis, lab tests every 6 months. So oral steroids, the greatest medication for back pain, believe it or not, that you can have in general. And it blocks here, so it blocks the entire inflammatory cascade, highly effective for radiculopathy and new annular tears, as I call low back attacks. Chronic pain, it's not very good for. So what are the problems? Well, gastritis, peptic ulcer disease like nonsteroidals, hyperstimulation. Patients will tell me, I've taken it, my back pain's better, and I'm up all night cleaning my kitchen. I gave it to my wife. It didn't work that way, by the way. So Cushing syndrome, where you get some swelling. Long-term dosage can cause hyperglycemic issues. So somebody you're going to do, even Dr. Evans is going to do an epidural steroid injection, and they're on insulin, you've got to watch them for their sugars. Long-term use, osteoporosis, possible cardiac disease, I've seen one case of theoretical AVN, and again, in thousands and thousands of people. Prolonged use can suppress the adrenals, so you don't give it quite often. High dose, short course, as I like to talk about. Membrane stabilizers. The gabapentin, which is Neurontin and Lyrica, everybody remembers gabapentin is the neurotransmitter that reduces postsynaptic inhibition. It's actually initially developed for seizure disorders, so it was a new, lesser problematic medication, and they asked all these people when they were finished, because it didn't work well with seizures, and a certain percentage wouldn't give them back. I said, why? Because, well, I had chronic pain and now it's gone. So it tends to reduce polarization and nerve action potentials in pain nerves. But what else is made up of nerves other than the pain nerves? The brain. So you take this stuff and it can make you foggy as hell, make you miserable. So some people can't tolerate it. Other people can. And you have to really play with the dosage on this. You don't have to play with the doses as much with Lyrica as you do with Neurontin, But some people at 100 milligrams, Neurontin's great. 300 milligrams, they're miserable. Other people at 300 milligrams don't even feel it. So you have to play with the dosage. It takes a lot of work. And it's great for nerve damage pain. Side effects, drowsiness, difficulty with concentrating, dizziness, swollen ankles. As I like to say, it either works well or it's hated. You just have to figure that out. It takes some time to work with these patients. Narcotics, big deal today. Wonderful drug used appropriately in the right patient. There's two parts, the spinothalamic tract opening potassium channels causing hyperpolarization, so it reduces the input of pain nerves, but it's also, doesn't say, releases excitatory neurotransmitters like dopamine. That's the problem because it also stimulates the limbic system and it gives people euphoria. I don't get it. I could never be a drug addict because I just don't get euphoria when I take these, but other people do. So you've got to be careful with how you use them. Complications, tons of complications. This is the big one. Respiratory depression does not change with exposure, but effectiveness of pain relief is diminished with continued use. That's what's killing everybody. Because you can take this and continue to increase the dose, because if you've taken it for a long time, you develop tachyphylaxis or tolerance, but the dose to respond to your respiratory system is the same no matter how much you take. So let's call it 40 milligrams or 60 milligrams. You're going to kill somebody because they're going to start taking it more and more because it becomes less effective over time in many people. However, there are some patients who do not develop tachyphylaxis. I've got patients taking 2 to 3 Vicodin a day for years and doing fine. And they're all stressed out because, unfortunately, with all the drug laws and all that, understandably so. But you can use this drug effectively if you're careful with it. Tricyclic antidepressants, doxepin and amitriptyline. These are old drugs. These go back into the 30s and 40s. And they increase norepinephrine and serotonin. They're effective to treat depression from chronic lower back pain. They're effective for fibromyalgia, but it makes the patient tired until equilibrium is reached. So you can actually use this drug initially as a sleeping aid. And they can take it every night because it's not like some of the Ambien drugs that can't be tolerated for more than 3 days a week. There are side effects to it. Very interesting. Ultram is 1 double bond away from doxepin. And Flexeril is similar to amitriptyline. We'll talk about how that's effective. So SSRIs, Prozac is the classic example. All block the reuptake of serotonin, good for reactive depression and fibromyalgia, very specific to each individual patient. You give somebody Prozac and they love it, and the next person hates it. You give them Celexa and they love it. So you have to be cautious about how you prescribe these. And you can have all ones that have norepinephrine reuptake inhibitors too, and that's Cymbalta. And that's just another way to treat pain. Again, this is pain and depression, but people with depression are hypersensitized to pain, and if you give this to them and cure their depression, they have less pain. So muscle relaxants. Curare was the first known muscle relaxant, but it killed the recipient, which was introduced by blowgun. And so you have to be careful with these. All induce sedation. There's different muscle relaxants. Cyclobenzaprine or Flexeril, again, is chemically similar to amitriptyline. Patients are not going to get drugged out of their mind with this. I don't think I've ever seen anybody who's been hooked on Flexeril. So it's a reasonably safe medication to give, but it can scramble people's brains, and they may not like it. So again, you have to experiment. There's tizanidine, which is good for spinal cord or muscular spasticity. We talked about the disease processes that have muscular spasticity. And baclofen is a GABA inhibitory agonist, and Soma is the same family as barbiturates, so you can get hooked on Soma, but it's a great drug used properly. And Valium is a great drug, but Valium has second and third pass effects. So, for example, Soma goes through the liver once and it's acetylated and stops working. Valium will go through the liver once, acetylated, and the secondary form works. And then it goes through the liver again and the tertiary form works. So you got to be careful that you don't overdose on Valium, but it's a great drug. Okay, so 4 specific disorders. The famous annular tear, and you guys know about this, inflammatory response. The symptoms of a simple annular tear can disappear within 2 days to 6 weeks. Generally, a one-time disorder will cause no further problems for the first annular tear. If you start to have more and more annular tears, you're going to have more and more frequent problems leading to, well, that's treatment, we know that, to degenerative disc disease. You have to think in terms, most of these problems are management problems. You're not curing people. You know, if you take an MRI 5 years down the road, those discs are never going to look any better and probably look worse. So the key is, how do you manage this people? And we talked about it. More fit, less weight, understand biomechanics, home exercises, bad routines will repeat, weight loss, neutral spine. So just start thinking about core strength and managing these people. These will be your friends for life because they're not going away. Core strength is the best way to splint the lumbar spine and reduce the stress on the discs. Start with isometrics, as we talked about. Avoid planks because of the shear forces that planks cause. And when muscles have developed endurance, an extension exercise program is mandated for something like this. So how can you keep them active in sports? How can you modify their sports? Well, patients will not tolerate flexion, which loads the painful discs, so they like extension. So start to think of extension sports. How can you extend them? But there is an exception. Cycling is a weight-bearing activity because the handlebars actually take the upper torso and it reduces or offloads the lumbar spine. So if you put the handlebars in the right position with the right stem and the right seat height, patients with bad discs can ride a lot. They can still, if you have a big climb, it's tough, but they can ride a lot. So shorten the stem, increase the height. Setting seat too high will cause pelvic rocking to cause pain. Golf. They can reduce the lumbar rotation and use hip rotation over the spine. So you have to teach them to lock the lumbar spine and change their drive. They can do it, generally. Running is difficult to modify. Shoes that have impact-resistant soles, running on dirt and grass can help. Longer hikes, hiking poles reduce the impact of the lower back. So if you're descending especially, they're very helpful because the impact is reduced substantially. Hiking poles is a key. Skiing can be improved with a more shock-absorbing style. Skiing on surfaces that are not hard-packed, avoid moguls, reduce a din setting. Well, yeah, they'll break out of their skis more frequently initially, but after the din setting, they get used to it, they ski with a softer style. Swimming, not weight-bearing, wonderful. And if you're built for swimming like Dr. Gill is versus me, it's another thing altogether. Sitting positions. So you can find different kinds of sitting chairs. This, I don't recommend just sitting on a Swiss ball, but they have the balls with the wheels underneath that are very helpful, that let you move and have cushioning to your back. A balance chair, where it's a knee chest chair, you've seen those before. They can be helpful for patients who have bad discs. And a lumbar roll behind the spine will increase the lordosis, offloading the lumbar spine for bad discs. So once you get to isolated disc resorption, then you have all the problems of the degenerative disc with the additional problems of aggravation with impact activities. So you've got to stop their activities. If they're a big tennis player, they shouldn't play tennis. I mean, you can play it, but you're going to get it pissed off. So it's up to you as to what you want to do. Extension protocol, cycling, golf, and swimming are acceptable activities. Swimming is in extension. Golf is flexion extension. Cycling has the weight on the handlebars. So they can do these things. Give them activities to do. Facet degeneration, as we talked about, remember that term? What are these spurs? All these years we've been together and you don't remember. Enthesopathies. Okay, so facet problems, as you can see here, facets load with extension, and activities that induce extension create pain. So the serve, overhead, and tennis, swimming, volleyball, overhead activities, such as painting the ceiling, can be prohibitive. So again, you want to reduce the stress on the facets. You want to rotate the pelvis backward to flatten the lumbar spine. Flexion protocol. If you manipulate, and you can manipulate above and below and not this level, then you can increase their motion and makes it a little bit more effective. If you mobilize this level, they'll hit you. SI dysfunctions, you can see bilateral findings, right? Chiropractic manipulation works great. The correct diagnosis is the key. Physical therapy modalities, possibly even prolotherapy. We haven't touched about this, but do you guys know what prolotherapy is? Some do, some don't. It's injection of a toxic substance into an area to create injury and proliferation of fibroblasts. I don't recommend it for any place but the SI joint. And you have to make sure the SI joint doesn't have a tear in it. And remember, muscles don't cross the sacroiliac joint. They don't cross it. So maneuvers, muscular strengthening maneuvers, are generally not effective. And we'll have Dr. Evans talk about radiofrequency evaluation or ablations.
So do you recommend an arthrogram before you to see the leaks?
If you're going to do prolotherapy, yeah. If you're going to do a steroid injection, no. But you're going to get it anyways because they're going to have dye within to make sure that they're in the joint anyways. Yes, sir.
I do prolotherapy, but you can change, a lot of times you're just doing dextrose, and there's nothing really toxic about dextrose, so you can use 5%, 10%, 15%.
But it's still a hypertonic solution.
Yeah, but you're creating a slight chemical irritation, but I think the back, right, control muscle, you put it into its hand, never hurt it.
Well, that's good to hear. So most of the ones that I've seen have been phenol and other pretty toxic.
People who use toxic substances and to create a really, really strong irritation, and those guys can get in trouble because if you're putting in a facet blindly, they think they're putting in a facet, but they're not doing it with C-arm, and then you're putting it with some.
Yeah. It's like putting the hand over the eyes and throwing darts. It's like, what are you doing? Yes, thank you. Okay, so what do you do for a disc herniation? So somebody comes in with a red-hot radiculopathy. Well, strengthen the core muscles. Find their position of neutral spine. Stretch the nerve without aggravating it. This is the art of taking care of these people. If you stretch it too much, they'll be pissed off at you. Treat trigger points caused by the nerve compression. Medications, which is the biggest medication you want to use? Steroids, right? Not non-steroidals, but steroids. Cardiovascular training, extension and neutral spine exercises for sciatica, lumbar support when sitting. HNP2, only when the nerve is less inflamed and can be gently stretched can leg flexion exercises be started. If the stretch too far, again, they'll have pay for it later pain. Oral steroids, the biggest deal for these, epidural steroid injections. You can take oral steroids and even 5 milligrams of Decadron orally. Where's it going to spread to? The brain, the spine, the foot, the hand, the elbow. When Dr. Evans puts a needle right next to that nerve and puts in 80 milligrams of Depomedrol, it's right on that nerve. Now, obviously, it'll go systemic a little bit, but the concentration of steroid is, what would you say, Dr. Evans, 1,000 times greater than an oral steroid? I mean, it's really a remarkable thing that works well. So foraminal stenosis and spinal stenosis, pretty good-sized ganglion cyst right there. Walking tends to aggravate the nerve pain and less posterior pelvic rotation, as I like to say, the Flat Earth Society. Flexion protocol, extension limitations for sports and activities. Foraminal stenosis, alpine skiing can ski all day. Why? Because they're bent forward. But what happens when they stand in a lift line? Miserable, unless they use their poles and they lean on their poles. You can see a lot of these people leaning on their poles. So cycling is similar. You can get on a bike and ride all day, but then when you try and get off the bike, you're going, oh my God, what did I do? That's part of the problem. Extension sports increase pain. Hiking uphill better than downhill. Why? Flexion forward. Right? So when you're descending, use your ski poles so you're bent forward when you're descending. Piriformis Syndrome, extremely rare. I've seen 2 or 3 cases in my entire career. You've got to stretch the muscle, which originates from the front of the sacrum and inserts into the greater trochanter. And you got to stretch it by internally rotating the leg. Ultrasound and massage, Botox can be used, but since the sciatic nerve is right there, there is a little bit of a problem because if you hit the sciatic nerve, that's points off. Isthmic spondyes, as you can see, there's the fracture there, there's the slip, and this person is naturally adapting the flat back position, right? This is just a standing x-ray, not an extension x-ray, and he's learned that if he extends, that draws this back. Therapy-guided stretching is undesirable as the goal is to stiffen the slip area. You want to stiffen these so they don't slip anymore. If you can figure out how to stretch these above and not affect that, God bless you. You've won the Nobel Prize. Degenerative slips are exactly the same thing, except in these cases they have central stenosis, and so they're not going to want to flatten their lumbar spine or extend right. I'm sorry, they will want to flatten but not extend their lumbar spine. Degenerative scoli is a problem because you're treating separate painful degenerative components. Look at the angulation of this vertebra. That's about 15 degrees. Do you think the guy's got foraminal collapse there? Probably. So do you want to treat that? Well, what happens to this lateral listhesis here and the angular collapse here? Some things you just can't devise a treatment protocol. You got to do the best you can. This is a disaster to try and treat. Thoracic hyperkyphosis. So look at where the plumb line is from C7. Drop it down. It's way in front of the sacrum down here. So you have to do the extension protocol. What you do is you get a bolster, a little foam, like a noodle from a swimming pool. You have them lay over the bolster and have gravity try and straighten this out as best you can. You can try and manipulate these people, and rowing machines are their biggest proponent because you're extending your spine and you want to strengthen those muscles. Lateral femoral cutaneous neuropathy or myalgia paresthetica. Very simply, it's the nerve collapsed underneath the inguinal ligament. It's lateral and anterior thigh discomfort, numbness and pain, weight loss if you have a pendulous abdomen, removal of heavy utility belts such as cops and firemen, ultrasound injections, and there are times that you need a surgical release. So labral tears, my partner Dr. Philippon will tell you more about these, but typically from cam and pincer mechanisms where you have to go back in and reconstruct this. Sometimes the nice thing is that Dr. Evans can tell me immediately on that day if I have a patient I think has a problem, because I'll beg and plead to get a hip injection, and they'll have a hip injection that he can do under ultrasound and they'll feel terrific, and that's the diagnosis for the most part. Greater trochanteric bursitis, not an uncommon problem. You have the big thick tendon here of the, you guys remember? Yeah, well, iliotibial band and tensor fascial lata muscle. And so there's a bursa between the big thick bone and that tendon or fascial component, and it can, think of a bursa as a water balloon with a little bit of 3-in-1 oil squished together. There's no friction. But if you have a bursitis, there's all sorts of miserable thickened junk in there, and it makes it very painful and inflamed. And so you can do ultrasound, iontophoresis, stretching of the tensor fascia, interbursal injections, and debridement sometimes. I think I've only sent 3 people out for debridement. And again, we talked about tennis elbow of the butt, right, which is the insertional tendinitis. Again, mimics gluteal pain from radiculopathy. You can press directly in there and they'll be miserably painful. Stretch the hamstring muscle by an SLR, and of course it makes it worse. But what also gets worse when you stretch the SLR? Radiculopathy, so you have to differentiate that. You can inject steroids, but that can hasten avulsions. I think Dr. Evans has been injecting PRP lately, have you? And that tends to heal it a little bit better. And then I've sent 2 patients for surgical reattachment. So that's the quick and dirty technique on how to make people better. There's arts and there's science. And sometimes if you don't know what's going on, you've got to do your best job. Questions?
Do you do steroid injections around myalgia paresthetica?
I'm sorry, around what?
Do a cortisone injection around myalgia paresthetica or emergency?
Around myalgia paresthetica? Yeah, I send them to Dr. Evans, who has a wonderful ultrasound device, And so we can actually look into the pelvis and see where to inject and how do they work?
I've gotten steroids around that area, very helpful.
Say again?
I have found steroids
You didn't think it was
decompress that.
Okay.
Because it's really as much a mechanical problem. The tool belt, the pants, the tough one. And then unfortunately, sometimes it'll happen after surgeries, like a retractor type injury.
Any other questions? Yes, sir.
Do you have a preference, upright versus recumbent for a second?
Say that again?
Upright versus recumbent cycle.
Depends on the problem. For people with central stenosis, upright is so much better than recumbent, but people with degenerative disc disease sometimes like upright, sometimes like recumbent. And if you've got an isthmic spondy, upright is better generally because you're putting the weight on the handlebars, but some people can't tolerate that. And so again, it's really the art as well as the science of this kind of thing.